Hey guys, I'm gonna be presenting today on a pretty simple topic, but we see it every day. Influenza is, we're having the mass hysteria about coronavirus, but I really think we should focus on influenza, which is one of the main things that we see on a daily basis. I see a food positive person and a complication of it as well. So, so, three objectives that I have today is to identify vulnerable populations. I think we all know, but it's better to just go over them once again, and so we can commit that to memory. It's the second objective. It's going to be just an overview of different system-based complication of influenza. And the third objective is to investigate further if there is an underlying condition, if the vitals and the physical exam don't really match how sick the patient looks. You have to look a little further and see if the patient has some type of immunocompromise or some type of disease going on at the same time. So the groups at the most high risk of having complications beyond less than 5, especially less than 2 years old, those are the ones that we usually try to prescribe Tamiflu to, so they will get through the influenza period faster and not go through complications. Groups over 65 years old, asthmatics, any lung disease, really COPD, or even cystic fibrosis that we don't really consider very much given the patients that we usually see here. Heart disease, anything from CHF, MI. I've been seeing a lot of status post cabbage people at UHB, so really have to keep those in mind. Diabetics, of course, any renal patients, cirrhotic patients, immunocompromised. We see a lot of HIV patients here. Cancer patients on chemo as well, or lupus patients on steroids, chronic steroids. Those are all important populations to keep in mind. So the first main complication of influenza is the most common, which is pneumonia. You can have a primary pneumonia, which is based only on the virus itself. Basically spreading to both lungs, as opposed to a secondary pneumonia, which we usually know from med school that the virus paves the way, sort of cleans the cilia out of the way, makes room for the pneumonia to colonize and create a consolidation there. And then you can have a mixed picture, which is a little bit of both. Okay, so the primary viral pneumonia, that's actually the more severe of the pneumonia complications coming from influenza. It's worse than the secondary pneumonias, actually. The main reason is that influenza, unlike other viruses, it really has, it attaches very well to our nasotracheal bronchial tree, and basically feeds off of a lot of our receptors that we have hanging on the tree. And it essentially multiplies itself very well. And when it multiplies itself, it actually does a lot of destruction to goblet cells, to other cells around it that are there to protect our lung and immune system. So this is a picture of a 44-year-old only having, this was day 2 of a viral influenza, and you see a lot of this reticular nodules around, especially on the right side. And then by day 7, it was spread to both lobes, and it almost looks like consolidations by day 7, but there was no growth of any bacteria in the actual collection. So as you can see, it looks pretty bad, and people get pretty hypoxic, tachycardic, so really suspect that. Okay, and then secondary pneumonia that we know from most viruses happens with influenza as well, and it's basically the hallmark is a clinical presentation of having fevers, cough, 3 or 4 days after you recover from a flu-like illness. So basically, the virus goes there, it attaches to the tracheobronchial tree. The tracheobronchial tree likes it. It helps to replicate it, and it starts to destroy the cilia. And not only it makes way for the virus to attach to it, but there are plenty of articles out there saying that the influenza virus actually promotes like co-infection through feeding of neuropeptides and other things that the virus actually likes. So that the bacteria actually likes. So it can cause an acute infection, but it can also cause colonization over time of these bacteria. And the most seen bacteria are, of course, strep pneumonia and then Staph aureus. And then every year we do see cases of community-acquired, community-associated methicillin-resistant S. aureus as well, which are more complicated in terms of cover for antibiotic-wise. I think I talked about most of the things. So next thing I wanted to talk about was one of the main complications that can happen. This is more rare, myositis. From a lot of our influenza patients, we get the history of myalgias. It's an important clue to us that it's not just a URI type of virus, it's influenza, right? But myalgia sometimes can be a little bit more complicated with influenza. It can actually, the virus or the cytokine storm that the virus causes can actually cause little compartments in the muscles, especially in the quads, the lower extremities, causing a lot of swelling and bogginess of the compartments. And some of these patients really have to be watched, especially our more immunocompromised elderly patients, because they can have a lot of disability in the long term from these. All right. So another important one is central nervous system involvement, as well as the myositis is the peripheral nervous system involvement, but essentially not in terms of pathophysiology, it hasn't been worked out as well as the respiratory has been worked out with influenza. We know how it works and how the virus gets there, how it colonizes, but in terms of central nervous system, it's not as well known, the pathophysiology. It's thought that most of the side effects of influenza in the CNS are actually because of the cytokine storm that it causes, and therefore it causes after a lot of edema in the area, and it can cause side effects associated with encephalopathy, encephalitis, transverse myelitis, aseptic meningitis, and Guillain-Barré. This was some of the MRI pictures of a 4-year-old that presented with a couple of days of cough, hallucinations, and disorientation. Eventually, they did imaging as well as they took CSF out. They looked like an aseptic meningitis kind of picture, but they couldn't grow anything out of the cultures. When they did a nasal swab, she was actually positive for influenza A H3 strain. So it was assumed that it was due to that. And you can see a lot of edema all throughout the brain, the frontal occipital areas and the, yeah. So, like I said, there are a couple of papers out there showing that a lot of the central nervous system, intra-brain and spinal cord effects of influenza are mostly due to the cytokines that it produces. It does produce quite a strong cytokine cascade, and from there it can cause edema and actual damage to the structures as well. And particularly for the blood-brain barrier, influenza can upregulate certain things like proteases that actually help to chew up the blood-brain barrier and help other things to get in there as well, other viruses that are circling around or other bacteria. So there are quite a few papers related to cardiac complications, acute cardiac complications from influenza. One of them being MIs. Again, not really well worked up yet in terms of the cascade that happens, but they have never been able to isolate the actual influenza virus in any coronary artery or any actual muscle from any of the myocytes of people that died of pericarditis or myocarditis, actually. So it's thought that it's similar to the cascade that happens with RSV, creating a lot of the inflammatory markers that can then make the environment hypercoagulable and destabilizing any of the plaques that are still there. That are already there. And these are usually, that's why you have to consider mostly in your cardiac patients and your diabetic patients. And so I'm not going to discuss particular studies, there are my references, but they did a lot of studies comparing MIs with people that were flu positive, swab for flu positive, and there was quite a correlation. And these are in various different countries. And then this one is a more obscure one. This is a study case. I thought it was really interesting because not only did it show site of influenza that can cause a lot of systemic symptoms, but also helped discover and that this patient ended up having lupus as well. So it was a 45-year-old patient, was presenting 3 days, fever, drowsy, and tachypnic with respiratory symptoms, as well as she was having, at some point, started having desquamation and petechia of the skin. They did a whole workup because of the petechia, the desquamation. They also included lupus-like markers, and they found that she had severely decreased C3 and C4. Eventually, they tested for double-stranded DNA and ANA. It all fit the picture of a lupus patient on flare, but she had a lot of acute respiratory issues as well. So there was something superimposed in that, and they ended up finding it was toxic shock syndrome, and that was from this patient not only tested positive for Staph aureus, but tested positive on nasal swab for influenza. So on her case, might have been that influenza was first there, paved the way for a lot of colonization of the Staph aureus and causing a lot of the toxic proteins to be released and ultimately trickle down to toxic shock syndrome and a lupus flare. So in summary, influenza can cause a lot of different complications, not just respiratory complications, but CNS complications, cardiac complications, and peripheral nervous system complications. Just keep in mind, it's still, I think a lot of research is still being done to really work out the pathophysiology behind it. Also, it's important to consider the high-risk groups, like we always do, but particularly in these patients that come in very ill, it's important to observe them for a little bit of time, see where it develops. And for those that test flu positive, but are like their physical exam is extremely out of proportion to how they should be, their vital signs, they are continuously tachycardic, continuously hypoxic, things like that. Really consider different more underlying unknown medical conditions that are there. I had a case just the other day at UHB with Dr. Z that was a really healthy 67-year-old patient, didn't take any medications, appeared really healthy, and he came in very tachycardic, tachypnic, hypoxic, and in the x-ray, basically what we saw was that initial picture that I showed you, it was really that you could see. You couldn't see bilateral yet, but we treated him empirically for pneumonia, swabbed him for influenza, and I don't think there was any actual consolidation there. And he was continuously hypoxic and tachycardic and ended up being food positive. And it was just, for me, it was really surprising. And then I followed his x-rays and he actually turned out bilateral. So he had to stay in the hospital for quite a while, and he ended up having some cardiac issues, elevated pulmonary artery pressures, and signs of CHF as well. So anyway, that is it. Those are my references. Thank you for listening.